everybody, I'm Monisha. I'm one of the PGY4s. Okay, so today we're going to be talking about basically quality improvement, quality assurance things. Going a little bit first into the history of quality and why we do what we do and where it all came from. Then going into, oh, that's not correct. Going into the CMS quality metrics that we're all beholden to, then to the different types of measures that we have to use to report on the things that we do. So first, the history. So starting in the 1950s, Florence Nightingale, a name that I think we all know, she started to track mortality outcomes with hygiene standards and kind of linked the concept of, you know, whenever you wash your hands, whenever you keep things more clean, patients tend to do better, have less infection. Then it moved to Ernest Codman, a Harvard surgeon. He tracked outcomes of his surgical patients. He began to look at his techniques and what he did, how the patients did after that, and ultimately founded the American College of Surgeons in 1913, and thereby established hospital standardization laws so that each hospital could report their outcomes, and each hospital had to adhere to a certain set of standards in order to maintain a certain level of quality. In 1951, the American College of Surgeons then joined forces with the American College of Physicians, the American Hospital Association, the American Medical Association, and the Canadian Medical Association to form the big bad, the Joint Commission, which is a private nonprofit organization that we all know and love. And then in 1965, the Social Security Act of 1935 was amended to establish Medicare and Medicaid programs. And this also allowed us, and we'll talk about this a little bit next with the CMS quality measures, to hold ourselves to a certain standard and in that way tie it to our reimbursements, and that way do better for our patients. So one of the ASEP people who does a lot of work in quality, his name is Tom Mayer, and he said, excellence is what we strive for, but consistency is what we demand. But in any case, the point is quality is, as a concept, was what we think of when, if a healthcare professional presents to the hospital, how we would want to be treated. That's the initial concept of quality. In 1990, the Institute of Medicine, later which became the National Academy of Medicine, said that the quality of care is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. So basically keeping up with the latest practices as much as possible and linking and increasing our propensity for our desired outcomes. I wanted to take a quick second and define the difference between quality assurance and quality improvement, because I think this is something that kind of gets conflated a lot. Quality assurance is kind of on the person level, and it's where we identify problems, develop and implement solutions, and we have follow-up to ensure that corrective actions have been effective. Whereas quality improvement is kind of looking towards the future. How can we continue to study tiny process measures to improve our healthcare delivery as a whole and as a system. In 2000, the Institute of Medicine, which was later named the National Academy of Medicine, as previously mentioned, had two large studies, one in Colorado and Utah, and the other one in New York. This looked at adverse events, and it kind of cataloged all the adverse events that occur in a hospital. It created this report called To Err Is Human, Building a Safer Healthcare System, and it showed that adverse events occurred in 2.9 to 3.7% of all hospitalizations, and of those, 6.6 to 13.6% of them resulted in a death, which kind of brought the focus more towards building a safer health system, as the name implies. They also created another report called Crossing the Quality Chasm, a New Health System for the 21st Century, a year later in 2001, which called for medical providers to adhere to these principles. They set out these aims for quality improvement, including safety, effectiveness, patient-centeredness, timeliness, efficacy, and equity, which most hospitals kind of create pillars, including New York City Health and Hospitals, create pillars to kind of guide all of our quality aims to focus on these. They kind of center around the fact that patients shouldn't be harmed by the things that are initially intended to care for them, and providers should not be harmed on the other side. And to demonstrate that the care that we provide is evidence-based and it should be tailored to the individual person, and that resources are utilized in a very efficient manner, which will kind of come into clarity a little bit later. In a 2008 article later discussed how the US healthcare system kind of achieves optimal outcomes as compared to other countries. You know, we spend a lot of money and our quality is not great in comparison. And they suggested what's called the triple aim in order to ameliorate this. They suggested care, which is improving the individual experience of the care that patients receive. Health, which is improving the health of the overall population, and cost, which is reducing per capita costs for populations. The Affordable Care Act that in 2010 codified these principles and called for CMS, the Center for Medicare and Medicaid Services, to issue rules for implementation of all of us, our accountable care organizations, by creating incentivized quality programs, which basically means that Affordable Care Act started to tie our reimbursements and our reimbursements to our outcomes, so that we would get paid based on how well we did and how well we were caring for our patients. In 2014, they later added a fourth aim to discuss improved clinician work-life balance and to combat burnout, which measures for which are still forthcoming. So moving to CMS. So CMS process measures are well-established processes in many ERs that we kind of look at, and these are metrics that we both look in our own departments for and are judged upon. These include our door-to-doc times, our door-to-balloon times for which is our threshold is about 90 minutes for our MI patients, door-to-needle times for our TPA, which is about 60 minutes. And they also include throughput measures, which basically look at how patients go through our emergency department. This includes median length of stay, which basically is like when you pick up a patient to when they're dispoed, kind of trying to minimize that as much as possible to make sure that the patient gets the appropriate care and gets to where they need to be. And then boarding times, which is something that we are all very well versed with. Looking a little bit closer at these hospital quality measures, the ones that I mentioned are kind of above, and then they kind of stratify them by the disease process. For example, for MI, median time to fibrinolysis versus median time to EKG, median time to PCI, and these are all metrics that are measured. For stroke, it's time to CAT scan, time to needle, and then I'm going to skip over sepsis, and then imaging for kind of culling our imaging for low back pain, kind of straying away from CAT scans or X-rays for patients that have had chronic low back pain for years, for which all this extra radiation really isn't going to yield anything additional. And so along with this, after the Affordable Care Act, there was a hospital value-based purchasing program that was created, which basically created a pay for performance program, which basically says that the better we do on these metrics, the more our hospital and the more as physicians that we get paid. These are a couple more in terms of readmission reduction, and these are things that you might run into as residents, we might run into, and as attendings, in terms of like trying to admit people. Like, say somebody is discharged and then they come back, and you might hear from the hospitals, hey, they just came back and they it's less than 30-day readmission. Could we try and obs this patient instead and see if they get better? In which case we can avoid being dinged as a hospital for this, really short turnaround time, this really quick readmission. So these are other things just to kind of keep in mind. So what are the consequences of all of this? We talked about the benefit, the pay reimbursement that we get for doing well on these, but CMS later began to collect data on the quality of all of these measures from a hospital-based care in 2009. And the hospitals that don't report the data, they receive a 2% reduction in all reimbursement. So that's something that we both sides of the street try to report these metrics in order to avoid this fee. So the next thing I want to talk about is MIPS, is basically at a more physician level, how can we be reimbursed? And this is something that's going to definitely come into play after we graduate. So the Medicare Access and CHIP Reauthorization Act of 2015, also known as MACRA, in case anybody ever hears of that, it eliminated the formula that capped increases in payment for the Medicare services. So what this means is it allowed physicians to be rewarded for high quality and high value care rather than solely volume based. That means that if I'm doing really well, or if my patients are doing really well due to the care that I give, I can still get rewarded for that rather than being rewarded solely for, seeing 5 patients an hour or whatever the case may be. The way that we report this is via MIPS, which is a merit-based incentive payment system. You can also do it based on alternative payment models, which is a whole side thing, but every clinician who cares for greater than 200 Medicare patients annually and have greater than $90,000 from Medicare reimbursements qualify for MIPS. And it basically, this goes through adjustments that you can get up to 4% extra or 4% decrease based on your quality outcomes. That was in 2019. And kind of going forward, they're increasing the caps on all of these things. The things that they kind of look at and the things that we report are things like the above, and I'm going to go through a couple of slides of these, but for one is appropriate testing for pharyngitis. For example, for a lot of these patients that are, not pediatrics, do we treat a lot of their strep throat? Like, are they going to have great consequences for it? This is something that, we should be a little bit more judicious about testing. Things like systemic antibiotic use for acute otitis externa versus the drops, using or avoiding antibiotic treatment for bronchitis or bronchiolitis, things that are more virally based. I'm not going to go through every single one of these, but kind of bearing in mind that a lot of the things that we are learning right now in residency and are kind of being hammered into us, these are things that later will be rewarded for. So that's nice. And for example, not getting a head CT on every single patient that hit their head and kind of being judicious and using the guidelines and the rules that we have to choose who we're going to CAT scan. So that brings me to the next point, which is the CDER. So clinicians, they can report through MIPS, but they can also report data through these qualified clinical data registries. ASAP, so many different associations have qualified clinical data registries. ASAP specifically is CDER, which is a clinical emergency data registry. And so there are hundreds, I think 300 or 400 different approved measures that you can kind of look through and select a certain number to report on and get reimbursed for. And you can either submit it for via EHRs or on CMS websites. And this is, by the way, a lot of stuff that our admin kind of takes care of us, and it's kind of behind the scenes, but something to kind of bear in mind if you work either in admin or sometimes if you go elsewhere where they require you to submit your own kind of reimbursement. And this is where, you kind of submit these kind of individual measures. For example, pregnancy testing for females with abdominal pain patients. You take all the patients that you've seen who are female with abdominal pain in childbearing years. You take the amount that you ordered this test for, and you report the percentage. And they have specific inclusion/exclusion criteria, and you can get reimbursed based on this. So I know I just threw a lot of things at you, but my main points basically are that knowing that these measures exist and kind of slowly familiarizing yourself with them, not necessarily in residency, but soon when you get out of it, can help you increase your reimbursement and help you provide better quality care to your patients. Also knowing that there are many different ways to report all these quality measures, and kind of knowing that the background of all this is that this came from trying to give better quality care to our patients and making sure that we're able to hold ourselves to a certain standard when we care for every single patient that we see. An unfortunate kind of byproduct of this is that now some of these are also tied to patient satisfaction, which is unfortunate that some of our job is now becoming more of a customer service thing, but also, it's nice to be nice. So thank you to the admin policy team for helping me go through all of this, and that's all I got.